Hello, this is Dr. Nina Kim from the University of Washington. Today I will be discussing the selection of oral hepatitis B antiviral therapy in the context of specific patient scenarios. There are a total of 8 medications that have been FDA approved for the treatment of chronic hepatitis B. But there are 3, entecavir, tenofovir disoproxil fumarate, and tenofovir alafenamide, that are considered the main first-line options for oral antiviral therapy. These medications emerged as first-line therapy because, in treatment-naive patients, they've all been shown to be highly effective in suppressing the virus in both e-antigen positive and e-antigen negative individuals, with evidence of long-term durability and viral suppression over the years. All of these medications are taken once daily. The first 2, entecavir and tenofovir DF, are currently generic. This table shows some other distinguishing features that would be helpful for a prescriber to know. In most patients who are treatment naive, the optimal choice of therapy could be any of these 3 agents, and features such as half-life or administration with or without food may factor into your choice. But there are patient-specific factors that will also influence your decision-making. We will be going over a few case examples to illustrate this today. I encourage you to pause the video after the question and consider your own answer to these cases to get the best learning from this mini lecture. Our first case is a 78-year-old male with chronic hepatitis B who received lamivudine as initial therapy in 2000, later stopped due to virologic breakthrough. He's not been in care since then and now presents with an elevated ALT of 55 and a viral level of 750,000. Serum creatinine and liver synthetic function are normal and the patient is asymptomatic. So, which of the following antiviral options is preferred here? Entecavir 0.5 mg once daily, entecavir 1 mg once daily, tenofovir DF 150 mg once daily, or tenofovir alafenamide 25 mg once daily. This patient appears to be in an immune-active phase of infection with evidence of liver inflammation and elevated viral level, so treatment should be considered. In this context, either B, the higher dose of entecavir, or D, tenofovir AF, are appropriate options, but I would personally consider TAF over the 1 mg entecavir option for reasons I will review. Lamivudine is our oldest oral antiviral for hepatitis B, but fell out of favor when it became clear that prolonged therapy resulted in high rates of virologic breakthrough, with drug resistance seen in the majority of patients by year 5 of treatment. It is therefore important to assess your patient's treatment history, as there may be some out there who've had prior lamivudine experience and virologic failure. Lamivudine resistance is an important consideration in our case, as it may compromise the durability of entecavir. This is because these drugs share the same resistance pathway, or more specifically, the signature resistance mutation for lamivudine, the M204V/I, as well as the compensatory mutation L180M, reduces susceptibility to entecavir and increases the risk of entecavir resistance. This partial cross-resistance between these drugs is the reason why entecavir is not the best choice of therapy for patients with lamivudine resistance. Even with a higher dose, 1 mg, up to 50% of such patients can develop entecavir resistance in 5 years. Our next case is a 55-year-old female with a history of hematuria and newly diagnosed IgA nephropathy. Her serum creatinine is 2.5 with an estimated glomerular filtration rate of 20. She has been taking tenofovir DF at the standard dose for chronic hepatitis B and has been virally suppressed for many years. No other prior therapy. So which of the following antiviral options is preferred here? Entecavir 0.5 mg every 72 hours, entecavir 1 mg every 72 hours, tenofovir DF 300 mg every 72 hours, or tenofovir AF 25 mg once daily. Here, either A or D is reasonable. I might consider A over D if there was concern that this patient would progress to more advanced kidney disease that would preclude the use of TAF. But what I would not opt for is C, renally dosed tenofovir DF or TDF, and I will explain why. While TDF is generally well tolerated with a good long-term track record for safety, it can rarely cause nephrotoxicity in some individuals. The mechanism of action is that TDF accumulates in the proximal tubules of the kidney, where it can damage mitochondrial function of these cells and lead to oxidative stress. This damage can result in reduced renal tubular function, acute kidney injury, and in more extreme cases, Fanconi syndrome, which is a condition characterized by multiple electrolyte imbalances. Risk factors for this include pre-existing kidney disease, older age, low body weight, and concurrent use of other nephrotoxic medications, and of course, use of TDF for an extended duration. TAF is a newer, more stable prodrug designed to deliver tenofovir more effectively to target cells, like hepatocytes for hepatitis B or lymphoid tissues for HIV. Compared with the 300 mg dose of TDF, 25 mg of TAF has 90% lower circulating plasma tenofovir levels. Presumably due to its low levels in systemic circulation, switching from TDF to TAF has been shown in multiple studies to improve bone density and kidney markers. For this reason, it can be considered safer than TDF in the context of kidney disease. Note, TAF does not need to be dose reduced for GFR greater than 15, but should be avoided in patients who progress to end-stage kidney disease, that is GFR less than 15, not on dialysis. Our last case is a 60-year-old male with chronic hepatitis B who's been virally suppressed on tenofovir AF. He's on no other medications. He is screened for latent tuberculosis, and a quantiferon TB returns positive. His symptom screen and chest x-ray are negative, and his provider wants to use rifampin for 4 months for latent TB treatment. So which of the following antiviral options is preferred? A. Entecavir 0.5 mg once daily, B. Entecavir 1 mg once daily, C. Tenofovir DF 300 mg once daily, or D. Tenofovir AF 25 mg once daily, which he is currently taking. The answer here is either A or C. Latent tuberculosis, or LTBI, is fairly common among people living with chronic hepatitis B. A 2022 systematic review and meta-analysis of studies mostly from North America found a pooled latent TB prevalence of 34% among people with chronic hepatitis B, reflecting shared epidemiologic risk factors for both infections. This finding highlights the importance of screening for LTBI in this context. Rifamycin-based treatments are now the preferred approach to LTBI treatment because they have comparable efficacy, lower rates of hepatotoxicity, and higher completion rates than isoniazid monotherapy. But it is important to note that co-administration of tenofovir alafenamide with any of the rifamycins is not recommended due to greater clearance of TAF with these medications, which can compromise its activity. Tenofovir DF or entecavir, on the other hand, should be compatible and could be used instead in our case. In addition to what we reviewed in these 3 cases, I want to highlight a few more clinical scenarios to be aware of. Patients with hepatitis B and decompensated cirrhosis, those with CTP class B or C disease, can receive any of these 3 agents, but we have limited data on the safety and efficacy of tenofovir AF in this setting. It is also worth noting that end-stage liver disease is a vulnerable period for kidney injury and that close laboratory monitoring is indicated for all of these meds, particularly tenofovir DF. Lactic acidosis is also a risk with the use of these drugs, especially for those with MELD scores greater than 20. We have limited data on entecavir in pregnancy, while in contrast, we have a larger body of data from registries for the use of either forms of tenofovir, in part because of its wider use in HIV. On the subject of HIV, those with HIV and hepatitis B co-infection should ideally be on tenofovir DF or AF, given the potency and durability against both HIV and HBV. Entecavir has only partial activity against HIV and is not favored as a first-line option in co-infection. This is also because lamivudine experience, as one of our earliest nucleoside analogs for HIV, is more common in this population. I hope this talk has given you greater familiarity with these agents. Be sure to check out our lessons on antiviral therapy on Hepatitis B Online if you want to take a deeper dive. Thank you for tuning in today.
The production of this Hepatitis B Online mini lecture was supported by funding from the Centers for Disease Control and Prevention.